playing games on that thing that I just named. But how? How does that work? Dr. Penelope McNulty is a neurophysiologist at Neuroscience Research Australia. G'day, welcome.
Thank you.
You are sitting here with this shaft of sunlight shining on you. You look like the angel for stroke patients.
Well, we try and do what we can.
Really, we should get a... This is quite a remarkable look. Sorry, I should move on. How did you work this out, that gaming like this is in fact good for you if you've had a stroke?
It was quite by accident initially. I had started researching stroke and how people control their muscles after stroke. And it was Christmas Day when my nephew was given a gaming console for Christmas.
Thank you.
And I was playing with him and trying to be graceful as I lost. And it occurred to me this could be a really good tool for using with people who've had a stroke.
So why that rather than juggling or finger knitting or whatever it might have been?
We use it as a tool so we can grade how we get people to use it. So it's not kind of all or nothing. We can choose which bits of it we use, how we increase the difficulty as they progress. There's lots of different games. They know the games. They don't have to learn something new. And it's really engaging. It's motivating. There's lots of prizes and scoring, and it really draws people in.
So you had the idea on Christmas Day. One, well done for remembering it, because not many people remember what happens at Chrissy Day. But how do you then lab test that idea, and how do you find out its effectiveness?
We do a whole lot of measurements. So our patients come in and we spend 3 days measuring them. And the joke in my lab is if you stand still long enough, we'll measure that too. So we measure how well they can use their hand, how well their brain can drive their muscles, what their muscles are doing. And then we spent 3 years getting it right, working out how to do it, what worked, what didn't work. And we're still testing it to try and figure out how we can help as many people as possible.
So it's not as though you have a stroke and you wake up and there's a Wii controller in your hand. It's not like that.
No, not quite.
So at what stage do you think about introducing it? And does it work for all people who have strokes?
Well, we introduce it after people have finished with their normal therapy. So they've been through inpatient and outpatient therapy before they come to us. And so far we've tested everybody from 21 years to 83-year-old people, from 1 month post-stroke to 21 years post-stroke, from very poor function to very good function. And every single one of them has improved their functional ability, which is really exciting.
So what sort of methods would have been used prior to this to try to recover that functionality you're talking about?
Lots of repetition of really simple movements. And the idea was to increase the number of repetitions. So the idea was 4,000 repetitions, over and over again, the same thing. And you know, if you've been to a physio for some kind of injury, you get these exercises to do.
Sure.
And you know they're going to help you, but do you do them?
I don't know what you're talking about. So it's got to be repetition, and so something like I'm thinking about other games. Pinball, for example, it's not repetition because it's irregular, isn't it? That wouldn't have the same efficacy.
Probably not. Also, it's a very limited repertoire of movements. And the nice thing about what we do is there's a huge repertoire, and we use it as a tool, so we can change what we're asking people to do and develop what they can do. And one of the nice things one of our patients said to us was that it didn't focus on her disability, but it worked on her skills.
How about that? All right. Now, how quickly then, in some of the people on whom you've tested this, have you found improvement? Is it rapid improvement?
Well, the program we do is over 2 weeks, and it's designed to be very brief but very intense. So they come to us for 1 hour of formal therapy on 10 consecutive weekdays, and we give them homework, a bit like being back at school. Starts at 15 minutes and it builds up towards 3 hours a day, depending on their progress. And in that 2-week period, we can see really significant improvements in their ability to move their bodies.
I understand one of the other things you've been talking about is another form of therapy that's not quite as much fun. Do you want to talk about something that's not fun?
Well,
it's a nice day. You want to go not fun?
Yeah, it's not fun. It works brilliantly well, and it's where we put a mitt on the good hand and it forces people to use their bad hand. And ideally, you wear the mitt for 90% of waking hours, and you have up to 6 hours a day of part-task practice, which is very repetitive, simple movements. It works. The patients hate it. A lot of doctors consider it imposes an additional disability on the patients. But it does work because it forces them to use that bad hand. And the big problem after stroke is it's easier, quicker, more successful to use the other hand, and they stop using the bad hand, it gets worse.
Is there any research on right-handed, for example? Are you right-handed or left-handed?
Yep, right-handed.
I was going to say be one of them. So if you have a stroke or if I have a stroke, are we more likely to lose more right-hand use as we are right-handed?
Well,
And vice versa?
it's actually quite complicated.
So a sinful left-hander's likely to... Sorry.
Well, left-handers are less hand-dominant than right-handers because the world forces them to be more ambidextrous. So if you are right-handed and you have a right-handed stroke, you're more likely to be more disabled than a left-handed person having a stroke that affects their left hand.
Oh, okay. So then if you're forced into using your left hand more, is that counterproductive because the world is right-handed, as you said?
Well, we know it also helps balance up things in the brain because the two hemispheres of the brain work together. So if one's damaged and one's not, that can exacerbate the imbalance between the hemispheres. So by forcing you to use your non-dominant hand, we can try and balance up the brain again.
Where are we at with stroke in Australia today? More strokes? Fewer strokes?
Oh, it's escalating. There's
How? Why? What's going on?
Well, there's over 60,000 every year, and that's because we have an ageing population and we have burgeoning epidemics of obesity, physical inactivity, and diabetes. And all of these are risk factors for stroke.
Right. And what does that mean for the research you're doing, other than the fact that a growing number of Australians, burgeoning perhaps number of Australians, will need the work you're doing?
There's an increasing number. People are surviving better after stroke because they have new treatments immediately post-stroke. But we're going to need to help these people because people are living longer and they're going to live longer with these disabilities. So we need to get them more functional, more independent, and more able to look after themselves.
What other areas is the conference looking at?
The conference is covering a huge range of things. I've been listening to things today about the structure of muscles and how that works to produce force. We've had a fantastic talk about pain and how the body interprets pain and what, in fact, pain is. All kinds of different rehabilitation strategies, how we control our bodies to do movement.
Thank you so much for talking to me. It's really interesting.
My pleasure.
And I will never look at a game console of any brand the same way again. Thank you.
Thank you.
Dr. Penelope McNulty, a neurophysiologist at Neuroscience Research Australia. And it is 18 minutes to 4. Very